This is hour 13. I am handing it off to Arjee. Nice to see you, but you are muted, so I don't want to. It's very nice to see you.
Thanks, Josh.
The hosting gig is super fun. Get to listen to really smart people, and then you have to listen to me in 40 minutes. So you have two smart people coming on, and then me.
Amazing. I love that. No, I can't wait to hear about your talk. Thanks, Josh. All right. Hi, everyone. Welcome again. And for those of you who are joining, welcome. Like Josh said, we are approaching our R13. I am Arjee Restar. I'm a Yale epidemiologist, and most of my work is in developing new methods in health equity and applying those, especially in developing interventions to improve gender equity, and in particularly within trans health. I'm also a co-founder of the Discern Collaborative, where we tackle disinformation and provide new methods on how to tackle disinformation in many areas in the sciences across legal and judicial channels. And so I want to thank everyone for sticking with us tonight. It's late night energy. I'm hailing from Seattle, and I'm sure everyone's hailing from across the world. So it's, late night energy is hard to come by. And so your participation means so much. We have a lot of presentations lined up for tonight. Really exciting work. They are master classes of all sorts of topics. So really grateful for all of the presenters that are sharing their knowledge today. So for those of you who are kind of in the late night mode, feel free to take a quick stretch, get a drink. I'm getting some coffee right now, and notice sort of the global audience tuning in. We have people from multiple countries, research institutions, and advocacy organizations. So feel free to drop in the comment to chat and say hi, maybe perhaps, add where you're joining us from. And while we get our first presentation ready, think about sort of the real world impact of HIV and TB research. The work we're seeing tonight really shows how science directly affects lives around the world. So to start with our first presentation, we are focusing specifically in Peru, which is a hub for the past decades for work that is really important around TB and HIV research. It's really fascinating how collaboration between local scientists, communities, and global funding agencies drives innovation. And so we'll hear from Dr. Jorge Cartagena, who is the Associate Investigator at Lima, Peru, specifically at Centro de Investigaciones, Tecnológicas, Biomédicas y Medioambientales. While we wait and think about sort of the challenges that researchers face in settings around the world, we need to think about how to design studies better in the most ethical and effective and culturally appropriate. So please welcome Dr. Jorge Cartagena, presenting their work on HIV and tuberculosis.
Thank you so much, and thank you for being here. Hope you can see my slides. That's fine. Well, thank you for being here in 24 Hours to Save AIDS Research. We are halfway now. And my name is Jorge Gallardo. I'm an infectious disease physician and HIV researcher working in Lima, Peru. And I'm happy to share with you what NIH-funded HIV research looks like in Peru through the lens of the Peru Clinical Trials Unit, and why keeping this work alive is important and matters for Peru, for Latin America, the United States, and the rest of the world. So let's go through some statistics first. Across Latin America, new HIV infections have increased about 9% since 2010, while deaths have fallen, but not enough. 2/3 of new HIV infections occur among key populations and their partners. That tells us two things. First, that prevention must focus on those regions and communities most impacted by HIV. And second, that the research needs to effectively serve these communities so the solutions fit real lives. When we say new infections rose about 9%, we're talking about thousands of preventable infections each year. And the pattern isn't just random. It clusters where prevention coverage is thin, where stigma is high, and where services don't match people's lives. I'm talking about work patterns, mobility, and the reality that many prefer community-based rather than hospital-based care. The lesson here is simple. Follow the incidence with support for research. Put studies and resources where new infections are actually happening. Which brings us to who is most affected. This figure here shows how HIV disproportionately affects certain groups in Latin America. Among men who have sex with men and among transgender women, the burden is far higher than in the general population. Key populations aren't just a label. There are people with specific barriers: fear of discrimination at clinics, interruptions of PrEP or ART provision during migration, lack of gender-affirming services. If we want incidence to fall, research must remove those barriers and not ask people to go around them. That's where NIH-supported implementation science and research comes to place. Now, zooming into Peru, we can see that the HIV epidemic is concentrated, the overall prevalence is low, yet among MSM it's about 10%, and among transgender women about 31%. Now, incidence in key populations is among the highest in the region and even higher than in sub-Saharan Africa, while PrEP coverage remains far below needed. That means that small gaps in prevention become big numbers fast. And this shows that Peru requires particular attention and sustained research support. So in response to the HIV epidemic in Peru, the Peru CTU was created almost 25 years ago as a platform built with the support of NIH networks. We operate 5 clinical research sites in Lima and Iquitos and host a regional HIV laboratory. Together, we have enrolled more than 6,500 volunteers across over 40 trials in HIV prevention, vaccines, and HIV and TB treatment. This really matters because it's not just clinical trials, it's installed capacity, highly trained people, state-of-the-art facilities, and long-standing community partnerships. This is what the Peru CTU and NIH collaboration created. On operations, we run dedicated clinics and pharmacies with quality systems aligned to international standards. So drug accountability, cold chain, and safety monitoring are rock solid. On labs, our regional HVTN facility processes PBMCs and advanced HIV diagnostics for Peru and Mexico sites, an investment of over $1 million. That means we can run complex assays at pace, not ship it all overseas. And the third pillar is the community. Advisory boards in Lima and Iquitos using good participatory practices to co-create recruitment strategies, refine retention approaches, and flag barriers early. That's why our retention is strong and our data is trusted. So Peru has been a high enrollment country in global NIH-funded HIV prevention trials. Starting with IPREX, Peruvian sites contributed 56% participants to the first trial ever showing that oral PrEP works. We then enrolled 42% of participants in the Americas Europe AMP trial, a landmark proof of concept study showing that broadly neutralizing antibodies can help prevent HIV. Then we enrolled 18% of participants in HPTN 083, the trial that showed that long-acting cabotegravir was superior to daily oral PrEP, expanding the prevention options for the world. And more recently, we contributed with over 42% of participants to Mosaico, the most recent large-scale HIV vaccine efficacy trial in the Americas and Europe. These numbers show capacity and speed. Peru sites have shown that they can deliver large, complex trials to global standards. But science only works when people are at the center. We have committed time and care in long-standing community partnerships over the past 25 years. Our good participatory practice approach means recruitment messages that use culturally tailored language, consent forms that are clear and concise, and schedules that fit real lives. When, for example, they told us that standard clinical hours excluded many participants, we added early mornings, evenings, and weekend blocks. When privacy came up, we adapted the flow so people can move through the clinics with dignity. We also lean on case managers and community educators. They help participants navigate visits when needed and connect people to services beyond the trials, mental health, legal support, or social assistance. That human link is often the difference between someone staying in care or stepping away, and that's what has made our clinical trials successful. Finally, we build capacity. Community partners receive training in research literacy, and many take leadership roles in protocols. This is not just a box-ticking exercise. It's the core of how the Peru CTU works. This truly is science with the community and not on communities. But here's some of the uncomfortable part. IPREX showed PrEP works in 2010, but Peru guidelines that formally include PrEP arrived in 2023. That's about 13 years from proof to policy. We cannot afford to repeat that with cabotegravir or lenacapavir or any other new HIV prevention option. So the game is really not over. We need continued NIH support for implementation science focused on the rollout and choice of new biomedical prevention options. So service delivery models come online with the science, not a decade after. And above all, we must keep investing in vaccine research, the only scalable population-level tool that can finally end this epidemic. So what's at stake if NIH research in Latin America stops? Well, if support shrinks, we risk losing highly trained teams, labs, and trial readiness built over 2 decades. Fewer options will reach MSM and transgender women in Latin America, where incidence is high, and therefore progress on the global HIV response will slow. And there's also a risk for the United States. Our transmission networks are interconnected across the Americas. Sustained incidence in Latin America can undercut the US ending the HIV epidemic goals. And there's also pandemic preparedness. The same people and labs that ran HIV trials stood up COVID-19 vaccine studies in Peru. So if that capacity fades, our readiness for the next pandemic will fade with it. So in summary, Peru has shown what happens when you invest in people, places, and partnerships. The burden in our region is unacceptable, so defunding HIV vaccine and prevention research in Latin America will only set us back. If we protect independent NIH-supported networks, invest in implementation science, and keep HIV vaccine discovery alive, we have a clear path to success. This is how we protect communities in Latin America, strengthen the US and global HIV response, and bring the end of the epidemic within reach. Thank you.
All right, thank you so much, Jorge, for your presentation. Looks like, do we have any questions for Jorge for now? I see you have a lot of fans on the chat saying hello and really wonderful presentation. I have one question for you. Perhaps if you could expand a little bit on geography, right? So like when I do my work in the Philippines, for example, around PrEP, HIV prevention, specifically for trans women, I think about sort of how do we deliver this in a way that is geographically fitting. Would you care to elaborate more in terms of what does it mean for what does it mean to deliver PrEP in geographical contexts, perhaps that may or may not be fitting, or like you may not have like, especially when you think about like rural areas, for example, or like disconnected, fragmented healthcare systems, like in the Philippines, where it's not super centralized. If you could think about that and sort of the power of community engagement and the power of communities to bring together services to each other. Any thoughts on that?
Well, thank you for that interesting question. Well, I will start saying that the HIV epidemic in Peru is basically urban. It's not much rural, but it's true that we have to understand that people that are living in rural places could have more challenging access to healthcare services, and that's how we need to think about in innovative service delivery models. For example, we can think about using mHealth to reduce the time of contact between the client and the providers. And we can also use another innovative tools, for example, teleprep or delivery of prep. So there are many things, many interesting proposals that are being discussed nowadays that can help reach those populations that are more in need, but when they have no good access to the healthcare services.
Nice. And do you have any insights on like the new methods or models for HIV delivery, like CAB LA, for example? Do you have any insights in terms of how it can be delivered to communities?
One of the things that we are seeing here in Peru is that there's a lot of burden on the clients for getting PrEP. So there's a long wait times. The clinic visits are too long. There's some cost associated. So really trying to and all this, this fosters stigma. So one way to reduce stigma and to reduce these challenges is to use some decision support tools, using mHealth tools to really expedite this process for people. And I think that implementation science work in Peru should really take into account the mHealth component. It's going to be, I think, really important to expand the PrEP coverage here in Peru.
Nice. There's one question from the chat, specifically in terms of outreach. And I think you may have already kind of touched base into this, but this person is very specific to La Molina, for example, into villages or outskirts like Villa Salvador. How do you, I guess, aspirationally, right? And like, how would you design a CAB LA that could reach communities in those parts?
Right. So the Peru CDU has 4 sites in Lima. They're kind of scattered through the city, so we can that way ensure that we have reach across all the city. And our community engagement teams are really well connected with community partners. So we receive participants from all around Lima, not just the center of Lima, not just the surroundings of our clinical sites, but from the entire city. So Lima is really a really heavy interconnected city. So our experience with community engagement is that we can reach a significant proportion of people that are needing care with our sites.
Thanks. All right, thank you so much. Before I let you go, I have one other comment, which is the IPREC study was super phenomenal in terms of desegregating trans women specifically. So really just grateful and thankful for the work that you're doing way back in the day when it wasn't as popular to do to desegregate data in that way. But we've learned some lessons there along the way, and I hope that future HIV clinical trials will continue to not erase trans people. All right. Perfect. All right. So moving on.
Well, hi, Judy.
Well, hi there. I'm multitasking. Are we on?
We are on live again.
Okay, then.
Figure that we should explain. We just had a little bit of technical difficulties, which means that you and I definitely should not be quitting our day jobs.
No.
and now we get to bring in, I believe Sara is
I think
gonna.
Sarah's queued up. Let's just tell everybody the platform seemed to have kicked us out, and we're trying to get back in. And so this is a new link, which hopefully speakers are getting, and we've got people observing. We're bringing people back on at a time. So Sara, thank you so much for your patience and forbearance. And why don't we just go ahead and turn to you?
Yeah.
Can you hear me now?
Yeah.
Yep, you're good, Sara.
So, well,
Thank
first
you.
of all, thank you for letting me go back on. And I'm really excited to be able to present. This is an initiative that is super important. And I was thrilled when I got an invitation to present about one of my favorite topics, menopause and HIV. So why is this important? Like worldwide, women are about half of the people living with HIV. And this is particularly true in sub-Saharan Africa, where women are more than 60%. And in particular, HIV is disproportionately affecting younger women, and it is one of the leading causes of death. Let me quickly turn off my focus. I don't know why this turned back on. So yet, most of the HIV cure-related trials are taking place in the US and Western Europe, where the vast majority of the epidemics is driven by mostly white men. And this is why a lot of cure research in particular is primarily focused on men. So on the top of it, there is a lot of, about half of the people living with HIV right now in the US are 50 years of older. And this is also like one of the biggest success, right? That people with HIV right now have access to therapists, they're living longer lives, and so they're getting older, and so they're facing some of the typical issues that older people face. And in women, obviously, this is also menopause and the menopausal transition. We also know that women with HIV transition to menopause earlier, and they can also experience more symptoms. And yet, there is not much that we know about menopause in general, and even less in the setting of HIV. It's important to note that aging and menopause are two very different concepts. They are linked, obviously, but there are different biological processes, and both impact health in a unique way. And you can see here, these are imaging from a paper that is actually came out when I was born, where you can see that as women age, there is an increase in cardiovascular disease. But then when we take a deeper look and we divide women for pre and post menopause, there is actually a big difference that is driven by postmenopausal women. And menopausal transition is understudied, and one of the key hallmarks in reproductive aging is the decline in estrogen. And we can see here, right, like in the perimenopausal, there is really an exponential decline in estrogen, which starts about when women are about 45, and then it decreases until women hit menopause. And when we look at the inflammatory profile during this period of reproductive aging, we can see that there are, some changes, and this is particularly true in biomarker of innate immune response. And if you look at this figure, you can really see how when we look, for example, at soluble CD14, which is a marker of monocyte activation, there is a steep increase exactly during the menopausal transition. So something is going on during these ages. These are data from one of our study, myself and Dr. John Korn and another, and a big group of people. We got an R01 a few years ago that was specifically designed to study the menopausal transition in women with HIV. And we used some, fancy methods like single-cell RNA-seq to really try to dissect the immune signature. And here you can see some data. This is a UMAP, which is a way to visualize single-cell transcriptomic data. And this is a mix of sample from pre, post, and perimenopausal based on the color. And when you look here, and you can see there are 2 dots that are red, this means there are perimenopausal. There is a huge increase in some genes that are related to interferon. This means inflammation. Again, it shows that something is going on during perimenopause that somehow triggers an inflammatory response. These are similar data where we take this CD4 transcriptomics and we create cluster of cells, and then they get ordered in a sequence from pre to peri to post menopause, and then we can look at single genes. And for example, interleukin 7 and JUNB. So interleukin 7 is again an inflammatory marker, JUNB and a transcription factor. And you can really see that as women transition from pre to peri to post menopause, there is an upregulation of this gene. So there is really a lot of evidence showing that during the menopausal transition, as a lot is going on, in particular estrogen is declining, there is some changes in the immune response. We are also looking at changes in the HIV reservoir, and these are longitudinal samples from ACTG clinical trials. And you can see here, these are men and these are women, and we followed them over 7 to 10 years. These are all people on antiretroviral therapy, and you can see that in the men, the reservoir is declining over time, while in the women, it reaches a plateau and it's even increasing. And our data were confirmed by another study by Raj Gandhi and his team, where they saw that in a subgroup of women who transitioned during the menopause, they also could see an increase in the reservoir over time. So again, something is going on as women age in the reservoir. And I think that this has been masked in many of the previous study, because previous longitudinal study mostly enrolled men. And so you can understand when you have like 80 or 90% men, they kind of take over the whole signal, and it's very hard to see what happens with the women. And then these are a subset of 15 women from the WISE cohort, and these women were really very carefully staged, and we got sample pre, peri, and post-menopause, and we were looking at viral induction. This means how much virus can be kicked off the reservoir at every time point, and you can really see how there was a significant increase over time in these women. When we look at clonality, this means like how the reservoir expands over time, and these are unpublished data from our R01 analyzed by Dr. Chaillon. You can really see how the clonality increases from pre to peri and post. And what is the mechanism, right? There was a paper from a few years ago from Dr. Karn's lab, where he was looking at various biomarker of HIV transcription. And he looked at the big library of compounds, and he was able to see that estrogen was one of the strongest repressor of HIV transcription. And if you look at this data, you can really see that if you try to activate the virus out of cells, you get a big kick. And when you add estrogen, the kick becomes much smaller. It's like estrogen can really suppress transcription. And this makes it even more interesting is when they tried to do the same experiment using cells from men and women, you could see that estrogen had a much stronger effect in women compared to men. So this really means that estrogen seems to affect the immune system and also the HIV reservoir. So to conclude, I think it's important to know that aging and menopause are not the same thing. So we need to be able to do careful study where we look at the chronological age, but also the reproductive age in women, and we analyze them separately. The menopausal transition is marked by a sharp decline in estrogen, which is really a key feature, a shift in inflammatory and immune profiles, and changes in HIV reservoir dynamic. And this has not been studied enough, and I think this has not been realized until very recently, mostly because a lot of the study have been done in men. So I do really think it's important to continue to fund study in women. We need to be able to enroll enough women in every study we do. We need to be able to enroll women in longitudinal study. We need to be able to enroll women at every stage of their life, like younger and older, and be able to collect all of this reproductive stages so that we can really clarify the role of sex hormone on the reservoir dynamic and the immune response and how chronological and reproductive age intersect. So thank you so much for inviting me and for all of the beautiful people that have been working with me on this important study. Now you're muted, Judy.
Dr. Arbach, you're muted.
Yep.
Oh, muted.
Sorry, I was saying, can I hand this back over to Arjee, and can somebody take me out of the back room, the green room?
Hi, Arjee.
Hi. Oh my goodness. Thank you so much for just kind of handling us through the technical issues. For those who are tuning in this new live stream, feel free to also continue to engage. Really happy to be able to continue the presentation with Dr. Gianella. Just really wonderful work and really sort of the importance of why a life course approach specifically for women are really important within HIV research. So thank you for that. Dr. Gianella, for what are some of your key takeaways or insights that you would want people to know about sort of the current state of research in the field and why this work is important? Could you take us through some of the things that you're currently thinking?
Well, I think it is like there is a lot that I want to say, so I need to organize my thought. But I do think that it's very important that no matter what research we do consider all genders. You know, obviously, we need to enroll women and men, but I want to stress gender is not binary. So we have a lot of people that we need to enroll in all Q research. And while this particular study was focused on cisgender women and endogenous estrogen, now that we established that estrogen plays a role in the immune system and in HIV persistence, it's very important to conduct similar study in transgender women to study the impact of exogenous estrogen, which are very often given at higher dose, and see how it affects cure and immune response. Because if we want to design a cure for HIV, it needs to work for everyone. Thank you, Cheryl. Yeah, it's my birthday.
Your birthday. Happy Esther birthday. And what a way to kick it off for sure. On that line of thought, Dr. Gianella, I wonder, what are your, because I think a lot of the times right now, what we're seeing in the field is that this practice of inclusion in HIV, like clinical trials, can often be seen as, competing for resources between different groups. So when we think about equity, when we think about inclusion, like principles, what are some of your thoughts in terms of in terms of including individuals where there may be underrepresentation, but still being able to say that each group sort of deserves their own platform and their own clinical trials, etc. What are your thoughts in terms of comparing gender-specific groups versus gender-inclusive groups, for example?
Yeah, and this is a very good question. We have to start somewhere, and this is why I think it is very important to compare male and female. Understanding the fact that gender is not binary, as I said before, and I do think that we need to get used to include gender diverse population, even with the understanding that maybe at the beginning we will not be fully powered to see a difference across all the gender spectrum. And we have a long way to go. And obviously the situation right now has set us back. But this doesn't mean that we need to give up. We need to keep fighting to bring back representation in all sorts of studies, and starting with representation in our teams, so that everyone feels welcome, and writing inclusive protocols, and with gender inclusive language, and allowing enough time and resources to do targeted outreach, and having peer navigators. And these are all wonderful stuff that we were starting finally to implement, right? Even at our clinical sites. And now I feel we got a little bit of a setback, but it's not forever. It's it's for now. And I love the HIV community. I love how we're fighting back. I love how we are not letting them dictate what we can and we cannot do. And
I'm gonna stop you there on that excellent point. I'm so sorry. I think we owe Sara the biggest amount of apology because our platform got completely wackadoodle when you were supposed to speak. I'm glad you were able to at least speak, but we are going to have to cut things off. Arjee, thank you for just balletic interjections here. And I think I'm being told we should move on to our next session. So thank you. Thank you so much. And thanks everybody for your indulgence as we've worked out what finally became a technological issue. We've gone through this event for however many, 13 hours without much.
I am Levi Butcher with AVAC, and I am playing host for the next 20 minutes. I'm joined by Dr. Josh Barocas, who is going to present on who's missing the overlapping risk of HIV and overdose. Josh, please take it away.
Levi, thank you so much. This has been just an absolutely fantastic event. I hope that folks have learned a ton from it. I am going to just spend not even 20 minutes. We're going to just talk about this overlapping risk population, because I think know at this point that there really isn't anyone across the US, across the globe, that hasn't been personally touched by either HIV risk, or overdose. So let's set the stage. At no point in our history have we had more tools to prevent HIV infections, treat HIV infections, or reduce the harms of untreated HIV. What are those tools? That's pre-exposure prophylaxis, which we've heard a ton about. Post-exposure prophylaxis, where you think maybe you had some exposure, and we can actually give you a short course of medicine to make sure that that virus doesn't take hold in your body. Antiretroviral therapy, if you are infected, we can treat you to the point of being suppressed, virologically suppressed, such that the virus doesn't even show up on blood tests. And finally, we have made advances in treatments for comorbid conditions, other things that affect people with HIV. So the toolbox is growing bigger every single day. And we heard about long-acting medications and different delivery systems. This toolbox is growing. However, having the tools, having the toolbox is not enough. We cannot reach people we cannot find and who we don't know exist. I'm going to repeat that. We can't reach people that we cannot find and who we do not know exist. And this gets at a fundamental problem that no matter how good our tools are, no matter how good our strategies are, if we don't know how many people are out there at risk, then we can't treat them. So the question is, who is missing from this conversation? Who is missing from our risk assessment? People who inject drugs. So there's a large population of people who inject drugs throughout the world. And there's significant overlap between that population and HIV risk. Currently, somewhere between 7 and 20% of all HIV infections globally are accounted for in people who inject drugs. We know that this population is up to 35 times more likely to have HIV than those who don't inject drugs. And finally, we know that at least, I shouldn't have put approximately, I should have said at least 1.4 million people who inject drugs worldwide are living with HIV. You're going to hear me say at least a few more times, and there's a specific reason for that. The take-home point here is that this population, people with substance use disorders, people specifically who inject drugs, are a high-risk group for HIV. But it's not the drug use itself that is a risk factor. It's the combo. First of all, drug use, like I said, is not itself a risk factor for HIV. Fentanyl, methamphetamine, cocaine, none of it contains the virus. It's the inadequate access to sterile injection equipment. It's the inadequate access to medications for opioid use disorder or pre-exposure prophylaxis that make injection drug use an actual risk factor for HIV. And ultimately, it's the criminalization of drug use that does this. So it's this combination of factors that leads to drug use being a risk factor for HIV. The problem is we don't know how many people are out there. So in the US, we count the number of people who inject drugs by what's called direct estimation. What does this mean? It literally means we count people more or less by hand. So two ways we do this. One is we walk door to door. And it sounds silly, but this is one of the ways. We have what's called the National Survey on Drug Use and Health, which unfortunately has been defunded and should absolutely be reinstated, have funding reinstated at SAMHSA in the United States, because this is critical for the lower estimate of the number of people who use drugs. What happens is we survey in households people, their drug use, their alcohol use, and other risk factors and risk behaviors. But you have to have a home. You can't be in jail. You can't be hospitalized. And so this leaves out a large chunk of the population. The other way that we do this is through pre-collected data, so administrative records, medical records, etc., whereby we count people by the diagnosis. So if somebody has an opioid use disorder and they have been seen by a provider and they have been appropriately diagnosed, and it's been diagnosed in a code, there's a lot of ands there, then that person gets counted. But we know that there are innumerable reasons why people who even access services feel shame. They don't get counted because they feel shame or stigma about using drugs. They don't have trust in the system. There are innumerable reasons. And so what we want to do is make sure that everyone who's at risk is counted. So our research team has pioneered ways of estimating the size of vulnerable populations at risk for and with HIV and overdose. So how does this work? I love talking about it because we have to start by talking about fish and wildlife. This technique, this method really came out of the fish and wildlife work so that we knew the size of different animal populations. And I want to be clear, humans are not well, we are animals, but we are not deer. We are complicated. We have complex processes, much more than deer, but we're going to use this to start. So at time one, let's say you go out in the woods and you find 60 deer and you tag them. You let them go. At time two, you find 30 deer, and it turns out that you see that 15 of those deer have already been tagged. Well, using a law of proportions, just simple proportions, if you grabbed 15 already tagged deer out of 30 on your second go around, then in theory, in an uncomplicated population, that 60 that you grabbed at the beginning is that same proportion of the total population of interest. So in fact, you probably have about 120 deer. This method was called capture recapture. And you can imagine why I don't use those terms anymore, because we're talking about humans, and this is a problematic naming. So we call this multiple systems estimation. And we have applied this method across multiple states, province in Canada, and across in some cases, the United States. And across the board, we have found that the prevalence, the number of people with opioid use disorder, which is a risk factor, especially if you're injecting them, the prevalence of opioid use disorder is nearly 4 to 6 times the size of the population that we think, or that we thought it was. And this all started, if you see down here, with a small study in Massachusetts that we did way back in 2017 and 2018 that was published in the American Journal of Public Health, in which we used, at that time, we called it a capture recapture method, and we had used linked data from across multiple systems in Massachusetts, where we found, de-identified individuals with opioid use disorder if they had been seen by emergency medical services or the hospital or substance use treatment, and in some cases, death records. And what we were able to do is, first of all, estimate the known population, who really was found in the data sets. And then we were able to estimate the unknown population. And even then, the known population was twice as big as what we thought it was. And then when we estimated the unknown population, it was 4 times greater. So why is this important? Because accurate estimates of populations at risk for HIV help us scale programs and services adequately. They help us appropriately allocate resources. They help us decrease disparities and increase health equity. And they make sure that we get treatment for substance use disorders to everyone who needs it and is ready to start. We want to give people that opportunity to start treatment, or at least start perhaps decreasing risk. The other thing is, knowing the size of the population helps us decrease stigma of substance use and HIV. It turns out that, like I said at the beginning, there is virtually no one at this point that has not been touched personally by substance use, overdose, and HIV. We need to get rid of the stigma associated with it so that we can continue to get to zero. And finally, why knowing the size of the populations? Well, we talk about 90, 90, 90 a lot. We talk about decrease. What about the 10, 10, 10? Who's missing? Ending the HIV epidemic means ending it in all populations. We care about that 10, 10, 10 that might be missing. So knowing the size of the population helps us plan and resource and make sure that we are advocating for improved health for everyone. So how are we doing? A good friend and brilliant colleague out at NYU, Dr. Noah Crossett, did this study a few years ago in the International Journal of Drug Policy, and she found that at least, here's that number, at least 7.6 million people in the United States have an opioid use disorder. And unfortunately, 1 million of those individuals have only received treatment. So only 1 out of 7.6 people have received medication for opioid use disorder that need it. All right, 2 more slides, 2 more points. If we don't know the size of the population, then we can't adequately resource the problem. What you can see is that across the globe, we are not implementing opioid agonist treatments like methadone and buprenorphine at the scale that we need. We're not implementing needle and syringe exchanges. We aren't providing high coverage of naloxone, which is critical because you can't treat people who aren't alive. We only have 17 countries with supervised injection facilities or supervised consumption facilities. And what I really want to hammer home is that we're really on a per person level, 35 needles and syringes being distributed per person who injects drugs per year is not nearly enough in order to prevent the spread of HIV, hepatitis C among people who inject drugs. And in order to adequately resource it, we really need to ensure that we know how many people are out there. And finally, Emmanuel Krebs did this beautiful modeling study that talked about the ideal implementation of prevention resources in 6 North American cities, 6 cities that have high burden of HIV infection. And it turns out that, I love this, optimistic implementation is the blue on the left, red is ideal implementation of services. And that red, look at how well we could do if we had ideal implementation in Miami. If we could get the services that people need to people in Miami, in Atlanta, in Baltimore, we could significantly decrease the burden of HIV, not eliminate it by 2030, but decrease the burden in the known population. And I say this again, there are still people out there that we don't know exist. And we need to make sure that they're accounted for. We don't have to know who they are specifically, but we have to know how big the population is so that we can make sure that we implement this ideal set of prevention resources. So why again does this matter? Because ultimately, we cannot reach people who we do not know exist. And in order to end the HIV epidemic, we absolutely must reach everyone. I'd like to thank the National Institute on Drug Abuse for funding this work and our team over the years. It has been transformative for our communities. We'd be further behind in both of these epidemics without the support and the continued funding from NIDA, from the NIH. And it is crucial that we continue this type of funding so that we can end both overdose and HIV. Thank you.
Thank you, Josh, for that wonderful presentation. I'm very curious. So not only is a reduction in HIV AIDS research funding going to be have a terribly negative impact on this work, but we're also looking at a reduction in funding for Medicaid coming up in 2026. Yeah. And I'm curious if you have any thoughts on the impact that that is going to have on this services for people for substance abuse, for HIV treatment, and like the combination of the two?
Levi, it's a fantastic question because the vast majority of people who struggle with continued substance use disorders are on Medicaid. And the only thing, and we say this a lot in harm reduction, that you can't treat someone who's dead. And what's keeping people alive and what's helping them sometimes in recovery, sometimes with decreased use, but certainly just keeping them alive is that access to services. So whether we're talking about access to ART, whether it's access to methadone or buprenorphine, we take away those Medicaid services. We take away funding for from SAMHSA, which is the government agency that sort of does service grants and service provision for substance use disorders. You take that away, and we are looking at catastrophic increases in HIV among people who are surviving, but also catastrophic decreases in our population because people will be at increased risk of overdose because we're not making it possible for them to stay on the medications that keep them alive.
I have to say that is harrowing. And with that, I want to just sort of throw up the call to action. Just if you care about HIV, if you care about substance abuse, access to treatment and healthcare, please call your representatives to let them know. 5 calls makes it really easy, really simple. Please do your part because collective action is the best way forward.
It absolutely is. And my last comment, Levi, is that and there have been studies that have shown this. At this point in the United States, this was about 5 years ago, I think that this study was done, 75% of the United States had been personally affected by substance use or overdose. 75%. This is not an us versus them issue. And that's the same. And if you are personally affected by substance use, then you are personally affected by HIV because that is the same. There are overlapping risk groups. And so if you are in that 75%, which is an overwhelming majority of people in the United States. And it actually, as I say that, it literally gives me goosebumps and chills and like sends this horrible feeling through my body, knowing that there are people that essentially everyone you walk by on the street has had some sort of devastating life-altering experience with this. This is an all of us issue. This isn't an us versus a, this affects us all.
I will volunteer my own, not my own story necessarily, but I am part of that 75%. Substance abuse is somewhat, has definitely hit my family. So I am familiar with that and I can relate. So
Thank you for sharing.
So
thank you for sharing. I'm sorry that it has hit you. I'm sorry for everyone that it has hit. But it does show us that that there is a collective humanity here. That this is something that is not a small issue. This is us. This is humans. This is where we are.
And the more we talk about it, the less stigmatized it'll be. So thank you. Thank you for all the work you're doing. Really appreciate it.
Thank you, Levi.
And for coming on and doing your presentation again.
My pleasure. Thanks, Levi.